recognise what you're articulating there. Thank you.
Thank you. Jonathan?
Thank you, and Liz really well explained actually, and I think I welcome this, and no need for a coffee from Ed for me, because I am really supportive of this, but I think the hard work now needs to happen in hardwiring that strategy through integrated neighbourhood teams, neighbourhood health, place boards, to have people accountable for tracking the delivery of that strategy. So I really welcome the strategy. That's great. But now we need to make sure we deliver it. And I think we've got some really good established mechanisms. As Tracy was just saying, we now need to sweat those assets to make sure that we get that delivery. So great start. Hard work now needs to happen. But I think place board chairs will be well up for this, because we can drive a lot of it through place boards, neighbourhood health, integrated neighbourhood teams, etc. Thank you.
Thank you. Christine, then Anna.
Yeah, thank you. Just building on what Dan said previously for the charity sector, I just want to mention about the social care sector, and particularly the independent sector. And I know that in the NHS health plan, that 10-year health plan, that social care was only mentioned 5 times. I'd like to reiterate the importance of joint working with social care, not just statutory services, but the independent sector, who supply nearly 80% of services. So again, it's just a plea, please, that the neighbourhood plans and the neighbourhood work actually includes the independent sector, not just the statutory social care sector. Thank you.
Thank you. Anna.
Thanks ever so much. I think also we need to look at this strategy not in isolation, because all the other stuff that's going on around Norfolk and Waveney, and I just wanted to highlight some of the partnership working that's working with the community trusts, with us merging and being a new trust from 1st of April. So in fact, I've had oversight of the children's world for now 7 years, and I'm very encouraged by the way we're going. So picking up I think what Dan was saying, so being able to, it's very fragmented at the moment, and if you've got additional needs in Norfolk, you've got one trust doing one thing and one trust doing another and one team. So having, I think, the opportunity to be able to offer a much more joined up neighbourhood-based service in parallel to this is really quite encouraging. So we're having to prepare patient benefit cases for NHS England for our merger, and I have sight of those, and they're very exciting. And I really do think, having had the lived experience of 33 years as a parent carer in Norfolk, we're actually on the move to some much better landscapes. So a bit of optimism, I think, to balance it.
It's always good to hear optimism. I think that's it. Oh, Ed?
Yeah, just to add to the kind of conversation, one of the things I committed to yesterday and already thought about is the delegation.
Thank you. I think that would be really welcome, because I know previously the place had, well, no budget. So yeah, that would be really, really welcome. Thank you very much, everybody. I think it's really important. Obviously, well, there'll be coffee and chats later on. I shall try to move us on so we have plenty of time to do that. But I agree. This is a real change. Can give opportunities. You know, it can give opportunities for new conversations, like we're talking about, more improved conversations, dare I say. I'm looking at Dan with the VCSC and obviously Tim and Daniel too. But, you know, those conversations are really, really vital, as is the conversations with social care. So I think this is a really good starting point. I do want to make a note that this did not need to come to the board, but I think it's really important that it has. And I really welcome it coming again in the future, as, you know, this will evolve until we have Norfolk and Suffolk ICB as in next April. But there'll be many iterations over the next few months. So I really welcome this coming and thank everyone. Thank you to Liz, thank you to Ed. And we have a recommendation. We're asked to, it's on page 15, is support the development of an ICB commissioning strategy for the proposed NHS Norfolk and Suffolk ICB, which will include reference to priorities within the Norfolk Health and Wellbeing Strategy / ICP strategy, which I think it does, and health inequalities too, as you said. So all those different strategies, we're looking to work them all together. So are we all happy to support that recommendation? Yeah, excellent. Thank you very much. That's excellent. Thanks very much, Liz. Thank you. Just so you're all aware, and you straighten your ties, etc., we're actually now on YouTube. I can see our IT person has arrived, so there we go. So you're now live out there in the world, or the virtual world anyway. There you go. Right, so the next item is item 7, which is on page 18, which is the pharmaceutical needs assessment for 2025. And here we are. We have Suzanne Meredith, who is the Acting Director of Public Health, and also Tony Dean, who is the Joint Chief Officer for Community Pharmacy Norfolk and Suffolk. So I welcome them, and once they're settled down, I'll hand over to them. Lovely. Is it you first, Suzanne? Thank you.
So thank you very much. You've already introduced Tony, haven't you? But yes. Tony's here to answer any of the difficult questions. And I'll start off by just giving an overview of where we are with the P&A. So as you all know already, there is a legal requirement to renew the P&A every 3 years. And we've had a steering group delegated by the Health and Wellbeing Board consisting of representatives from the LPC, the LMC, the ICB, lots of initials, Health Watch, and we've been assisted by an external company called Soar Beyond, who've got experience writing P&As in many other areas. So I'd first of all like to say thank you to those people, because they've devoted quite a significant number of hours to putting this together. The P&A you have in front of you has been signed off by that steering group. It's been signed off by myself as the Acting Director of Public Health in accordance with the process that the Health and Wellbeing Board set out. And as you can imagine, there were many hours spent considering all the information to come to the conclusions that have been made. The document is a long document. It's a technical document. It's formal because it's going to be mainly used by the ICB colleagues to make decisions about market entry to the community pharmacy list. And so therefore it has to be as robust as it is, because it's practically a legal requirement. I'd like to confirm that we've followed the specified process, including that 60-day formal consultation process that's required legally. So in the P&A, it sets out the provision we have in Norfolk. We've got community pharmacies, we've got the dispensing practices in rural areas, we've got the distance selling pharmacies who provide to people's homes, they deliver to people's homes. And additionally, we sometimes have services, we've noted the rural challenges that Norfolk faces. And particularly the current context we're facing, which is both nationally and locally, around where pharmacies have been closing recently due to viability, commercial viability. Since 2023, there was a change in the pharmacy regulations, which meant that pharmacies that had previously been open for 100 hours could now reduce that to 72 hours, which of course led to reductions in weekend and evening opening. And we've seen that happen in Norfolk as well as nationally as well. And that's been noted in the P&A. There is no formal definition there about what constitutes a gap. So when the steering group has been considering whether we have any gaps put to us regarding any unmet need, and we've considered any feedback that Health Watch received as well. And during the process, we did receive additional feedback relating to lived experience from members of the public who'd had issues around service provision, around quality of service. Now that falls outside of the scope of the P&A, but it's really important that we capture that and pass it on to the relevant organisations and groups that deal with that. So that's what we intend to do with that information. So the final conclusions are that the pharmacies are well distributed across Norfolk, serving the main population areas. We've noted the rurality challenge in Norfolk, but there was no evidence provided to us around unmet need or adverse outcomes as a result of that. And so overall, after really, really long consideration, we've concluded that overall there is adequate access to essential services across Norfolk, noting the more limited access at weekends and evenings, but that is consistent with national patterns of pharmacy provision across the country. The National Pharmacy Contract does not, unfortunately, provide for 24/7 coverage, so we've got to note that. And we know that there will be changes in the future, so the steering group will continue to meet on a quarterly basis to, if there's any other changes in service, we will be able to then assess again whether we consider there's any gaps and make the relevant recommendations. So I shall pause there. Thank you, Chair.
Thank you, Suzanne. Right, I've got Joe and then Alison.
Thank you. I was sad enough to find the presentation on the pharmacy needs assessment really interesting. I hadn't realised, all the differences, and it was good to understand that you don't deal with the quality. We've recently had a pharmacy in Kings Lynn in South Wootton closed down, and I wonder whether these closures have been captured and factored for in the pharmaceutical needs assessment.
Thank you.
Shall I answer?
Yep.
Yes, so there was a cut-off date for doing this document, but the steering group then considers going onwards any other further closures, and we take each one individually and assess whether there's any appropriate provision in that area that will cover the closure. I don't know, Tony, did you want to answer anything else on that one?
Yeah, I mean, I can't get drawn, I'm afraid, on individual contracts. That will be inappropriate of me. But there is a process where there's a standing group that looks at the ongoing picture between the P&A publications, and then that can decide if it thinks something is significant to issue what's called a supplementary statement, which clarifies what we feel the position is on that. But it is a statement of fact that a pharmacy has closed. In between that, there are application processes that allow pharmacists to apply for unforeseen benefits. In other words, no matter what the P&A says, we've identified something, and that is a process that an application can still come in, even though the P&A says no gaps, and then they will have to make their case as to why the P&A didn't take that into account.
Thank you. I've got Alison, Tracy, and then Liz. Alison.
Thank you. I usually talk in a strategic way, but I'm actually going to take this opportunity to speak as a local member representing a community. I'm pleased to hear you say, Suzanne, that although there isn't a remit within the pharmaceutical needs assessment to review quality, that you have taken the feedback and the anecdotal evidence that you've heard through the consultation and will be passing that on. Because I think from a community perspective, residents really struggle, and they certainly struggle in my community where we've got a poorly run franchise pharmacy that has very inconsistent pharmacists available. So on many days, the door will just be locked and people can't get in, but they're not allowed to go to the GP surgery because the GP surgery, whilst it has a dispensing facility, is not able to dispense to people who actually live in the town, but it can dispense to somebody who lives in a village 2 miles outside of the town. That for the public is very difficult to understand and to explain. So I think there needs to be some kind of messaging to help people to understand this whole complexity around a pharmacy that sits within a GP practice, which is your GP, but you can't access pharmaceutical services. And people who actually have run out of medication, then just being told, well, you'll have to go to Norwich. Well, not everybody can travel the 12 miles into Norwich. So I just wanted to feed that back because it is a very real problem. And I noticed that you used the word adequate services. We should be looking at good or better than good, actually. And adequate is only just about, meaning that people are getting a minimum service, in my view. And I just feel it would be wrong of me to sit in this meeting and not voice those concerns that come directly from the community that I represent. Thank you.
Thank you. Thank you. Did you want to say anything on that?
I think Councillor Thomas has basically said that the P&A doesn't cover those quality issues, but we will make, and if there are any particular feedback you want us to pass on to the ICB, for example, then we will do. Thank you.
Thank you. I'm wondering if it's something that the Health Overview and Scrutiny Committee could look at in more detail. And like you say, it shouldn't be complex.
It's that complexity
understand.
that patients,
Yeah.
you know, don't understand. They go
Yeah.
to the pharmacy, the door is closed because there's not a pharmacist. They can't provide a pharmacist, therefore they don't even open the chemist. So you can't even go in and buy over-the-counter medication. And people are then saying, well, my prescription, it needs to be, you know, I need to collect it. And then they're stuck without any medication. And for some people, that could be really significant because if they're on regular medication for pre-existing conditions, they need to, you know, as an ex-nurse, they need to stay on them and have them regularly, not have to wait 2 or 3 days until the pharmacy opens again.
That's what I mean. Need to simplify it rather than make it as complex as possible. Anyway, Tracy, and then we've got Liz and Alex. Thank you.
Yeah, thank you. I think responding to that, I think certainly with the electronic prescribing system, there are ways to, if a pharmacy is closed, that medication can be picked up at other places, but appreciating with the geography of Norfolk and Waveney, that is quite a challenge, isn't it, for many people, and transportation issues, which I think you've noted within the report or the needs assessment. I mean, I always enjoy reading these because they're so thorough, there's so much information that I think can really inform the way we may want to deliver pharmacy services in the future. My question is particularly around about the asks of pharmacies going forwards, Pharmacy First, for instance, and those other things, because pharmacies are essentially, you know, key community neighbourhood facilities. So, you know, how do we support pharmacies? How can we do that to kind of be able to deliver and work in partnership for all those kind of asks as pharmacies, you know, moving forwards? I know the range of services are just growing increasingly, Tony, that pharmacies do deliver right now. So really a question on that respect, I guess.
Thank you.
Thank you, Tracy. And if you don't mind, before I come, I will answer respond to your statement, Councillor Thomas. The regulations around pharmacy are outdated to a certain extent. The regulations around dispensing practices were set up to make it able so that a practice could dispense where it wasn't viable to open a pharmacy. Now, obviously, we now see those historically carrying on in places where we've got market towns with 3 or 4 pharmacies, yet the practice is still dispensing. So there are lots of archaic, you know, aspects to the contract, and indeed our supervision requirements are almost unique in that if the pharmacist themselves does not turn up, and remember nearly all pharmacies can only afford 1 pharmacist nowadays, that we are not allowed to open the doors. That is a regulation. Whereas a GP practice, if a GP doesn't turn up, then the nurses can still operate, etc. Those supervision regulations are being looked at and being consulted on at the moment that might allow registered technicians to supervise some aspects of the process so that more can be done when the pharmacist isn't there. We are suffering from and continue to suffer from a massive shortage of pharmacists, and this area has been perhaps hardest hit nationally of all of them. You know, as a result, you know, a pharmacist goes off sick in, you know, Brundle, did you say, sorry, or wherever, then in which case, you know, you might be looking at pulling a pharmacist from 100 miles away, and you know, the feasibility of getting that there in the day is sometimes very, very difficult. There are many reasons for that, including the additional role scheme that took many pharmacists away from community into PCNs and other networks. But I could, you know, we could go on all day about the workforce issues. But just to sort of contextualise, Tracy, back to your point, community pharmacies faced a real-term cut in funding in 2017. The funding was then frozen until 2025, when we got a small increase. So we have suffered from a real terms decrease in funding of something like 35 to 40%. Now, we got some back last year when the new government came into being, but the new government commissioned a report into the actual costs of running the current community pharmacy network and implementing the contract as it was at that stage. 40% or 45% of pharmacy owners are putting their own money in to subsidise their businesses. So that is the background to which closures and cuts back in staff and everything are happening. So I think it's really important that people understand the pressures. Our guys are doing, frankly, an amazing job, and through the pandemic they kept the doors open, etc., through these cuts. And you know, there are operational reasons, and I never said I would defend poor practice, and I won't, but what I will do is contextualise why they're facing the pressures that are under, including, frankly, a semi-broken medicine supply system where we can't get medicines. We have to spend hours a day on the phone trying to, source medicines for patients because the supply chain is severely damaged. So the pressures facing our pharmacies are absolutely huge. That's not to say that I don't understand that, the pressures on patients, and we all want to work together. So Tracy, it's about what the solutions are. And a couple of positives. Frankly, the clinical services are very, very welcome. Most pharmacists working in community don't want to just check prescriptions all day. They actually want to use the skills that they were trained for. And the new services like the Pharmacy First service, etc., limited as it still is, has been particularly welcome. Hypertension service, contraception service, all of these things are making it so the public can go into pharmacies for far more clinical services, and that is very welcome, provided it is adequately funded. Another positive, I would say, was the delegation of commissioning to the ICBs. For the best part of 10 years, we sat in the wilderness with barely contract management and certainly not commissioning or support. And since we've gone to the ICBs, then we have seen dedicated people who understand the community pharmacies, for us to deal with within ICBs, and they have been incredibly helpful to us, and have, things are starting to actually move forward. And locally, the picture is I would say, very, very encouraging. And I would say the same for Norfolk's public health commissioning. It is of a high standard. I see public health commissioning across the country, and what they commission from pharmacies and how they commission it is very well done. So there are some real positives there, but when 90 to 99% of a pharmacy's funding comes from the national pot, then inevitably local can only deal with a certain amount of the issues that are frankly of national making.
Thank you for that context, Tony.
Sorry, Steve.
No. It's really important to hear, really. As you say, this is a national problem, not so much. It is a local problem, obviously, for people on the ground. Of course, but it's a national issue that we need to really address. So, thank you. Okay, I've got Liz, Alex, and then I've got Penny. Liz.
Thank you, and yes, Tony, thank you for that really useful context. It was interesting, but I would like to refer back to Councillor Alison Thomas and Councillor Joe Rust's comments, in that I'm also from an area where we are experiencing quite significant issues with local pharmacies, and it seems to me that I wonder whether, and I'm also a local authority person, so we tend to get a little bit obsessed with risk. But it seems to me in this report, when we're talking about adequate services, I wonder whether we have addressed that element of risk significantly enough, seeing what's happening in some of our local areas, and particularly in terms of that contract. And I think you possibly referred, Tony, to that possibly being looked at. But when we have contracts where pharmacies are so obviously failing, and failing the local community and people with serious health conditions, that we can't actually move on from that contract. That seems to me a huge level of risk to saying that we're adequate in our provision. So I might have got that totally wrong, but it surprises me that risk isn't more overtly identified in a needs assessment.
Thank you.
So I would say, so the PNA itself is looking at the locality of the pharmacies, and it's unfortunate that there's a separate issue in terms of the quality and provision of those pharmacies in terms of their services that they provide. So we are a bit restricted in the PNA in what we're allowed to put in it, but you're right that there are then additional things we need to address in terms of the quality and the commissioning of those services, which do fall outside the scope of the PNA, but are definitely very vital that we address them.
Yeah, please do, yeah.
Yeah, I mean, the ICB does run a risk register of these things. Where a pharmacy, the PNA is about whether you've got the right number of contracts, and then it is up to the commissioners to, look at a pharmacy that might be struggling. And we are encouraging our pharmacies to come forward more, because, frankly, pharmacies have never struggled like this before, because we've never faced the kind of problems that we have before. But where a pharmacy is starting to struggle, the last thing that will be helpful is another pharmacy immediately opening, because I've said that most of our funding comes from a central pot, the global sum, which kind of how many pharmacies that can feed is finite. And as I've already said, there's a £2 billion shortfall. Basically, the country is not is not funding the network it already has. And if a pharmacy is starting to struggle and you indicate there's going to be a new pharmacy there, well, A, that pharmacy probably will, it's inevitable that will close, whereas other parts of the NHS will be supported to improve, etc. So first of all, we need to work with that contractor and try to improve it. And you know, my body and the ICB do work very closely where that's identified to try and improve things. But even when a pharmacy closes, there needs to be a careful thought about whether it actually needs replacing or not, given the fact that the network is not being adequately supported. We are seeing technical advantages in pharmacy. That means a pharmacy can potentially cope with more than it could in the past. For a start, staff skill mix and technicians have been able to supervise an awful lot more things is one thing. AI technology within our pharmacy systems means that the pharmacist, can be alerted to just the prescriptions they're particularly in need of looking at and give them more of their time to services, etc. And we have the potential for what's called hub and spoke. The legislation has just been done where the pharmacy can basically send the prescriptions to a central machine to be dispensed, and then the completed item, not the ingredients, the completed item for that patient comes back for the pharmacy to then hand over to the patient and give the advice, etc. All of those can increase capacity. So a knee-jerk reaction of one struggling, let's open another one, just destabilises the network, frankly, and means that the ones around it are not able to invest in that technology and staff and premises. So it is a perfectly logical desire that one's struggling, therefore let's open another one, but actually it will be completely destabilising, and the P&A does recognise that.
Thank you. I'm going to go to Ed, and then Alex, and then Penny. Thank you.
Just on an action, I think it'd be helpful for me to bring a paper on risk, as you say, to the public ICB board, so we've got a clear picture on risk and what we're doing, but also thinking about place boards that in terms of delegation, that each place board might want to have a really granular look at the pharmacies. And you mentioned the scrutiny committee too, which is in your gift as well.
Would be a good place to.
Yeah, so we should really have a close look at this.
Okay, lovely. Thank you. Thank you. Alex.
Thank you. I'm speaking very much from the independent patient voice perspective here, having been involved with, I think this is our third PNA since Healthwatch's inception back in 2013. From a process perspective, we consider that this has been the best process that has actually operated to date. Lots of lessons have been learnt from previous PNAs, and which led to actually greater time being factored into the whole process. The caveats that I will come up with are that there's a huge problem in actually explaining to the public what a PNA really is. And there is a difference between want and need, which has actually been very adequately demonstrated here today. And somehow we've got to get that message across. So moving forwards, I think, Ed, you're quite right. If we can sort of come out with a much wider public message, and again, understanding as somebody who lives in the north of the county, my nearest bus stop is 4 miles away. So if I didn't have access to to my own transport, or I was elderly and infirm, accessing local pharmacies would be nigh on impossible. I think the only other thing I'd like to say is that one of the public bits of feedback that we constantly get is 85% of people prefer face-to-face pharmacies. And within that, they like to be able to discuss their medication availability, and location and opening times are of paramount importance. But I think that, the County Council should be commended, a public health team, for the way in which this has been undertaken this round.
Thank you, Alex. And Penny.
Thank you. Obviously, pharmacies are very much integral to any community. And I just really wanted to ask the question. The pharmacies offer various services now, which I'm delighted to see. And it does, obviously, it probably takes slightly pressure off the general practices when they offer. But do you inspect the pharmacies to see whether they're suitable to offer, for example, flu injections? Because I can tell you my local pharmacy, it probably isn't the best place to be put into what I would call as a storeroom, with boxes, half-open boxes around you when you're getting, you're receiving treatment, i.e. injections. Now, and it's really quite rough. So it's not it's not really very good place to do that. So do you, or is there any processes? So if a pharmacy offers to take up the offer of we will give you COVID injections or the flu injection, it was the flu one for me, that the premises are inspected from time to time to see whether there are suitable rooms that the pharmacies are using? Because the one they gave me to use was not suitable at all.
Again, I can't get into individual cases, but in answer to your question, we're inspected by a number of sources. The GPHC, the General Pharmaceutical Council, has inspectors that go around and inspect pharmacies. And the ICB have a quality team that also goes around. So where there are concerns, and that is raised to either of those things, that will be looked at. And certainly, if it is not my organisation's job is not to inspect pharmacies. We are a representative, supportive organisation for pharmacies. We're not there to police them. But those two bodies are, and there's also a delegated sort of contract management role to the ICBs in the East of England contracted out to the Herts and West Essex team, and they have a team that goes and looks at the basic contract stuff for community pharmacy. So there's actually three separate inspectorates that can visit pharmacies. Now, whether they visit often enough, we can that's not for me to answer. But there are relatively few complaints about community pharmacies, and when they are raised by the proper channels, then they are looked into and investigated, and put right in a supportive manner, which is how these things should be handled.
Lovely. Thank you very much. Thank you. I think it's been a really interesting debate. Obviously, as I say, the pharmaceutical needs assessment is a technical document. It doesn't address many of the issues that we've discussed here, and I think that's why we need to sort of widen this out, as has been suggested. So, yeah, it's very complex, but there's clearly a need for change at national level, dare I say. Obviously, local level things have changed. You say we were under NHS England, and now we're under the ICB, which is a huge change. That's only been 2 years, is that? Yeah, 2-3 years, so not very long at all, really. But, yeah, we're moving in the right direction. But we have a recommendation, which is on page 19, which has endorsed the findings of the P&A as part of the Norfolk Joint Strategic Needs Assessment. I would also ask that we include here that we ask the place boards, the ICB board, and Norfolk Health Overview and Scrutiny Committee to do a deeper dive into pharmacies across Norfolk to see what is the situation and what it needs to be and how we can change it for the better. So that would be my suggestion, to include that on the recommendation. Is everyone happy with that? Yeah? Okay, good. So you're happy to endorse that recommendation? Yes. Thank you very much. Thank you. Thank you, Tony. Thank you, Suzanne, for that insight. That's really, really helpful for everyone. Thanks very much. Right, our next item is on page 231, which is the Better Care Fund Q1 and Q2 returns, which I'll just let Ed and Karen settle down. So I've got, so it's over to Ian Wake to introduce this, and then we pass it over.
Thank you very much, Chair, and good morning, colleagues. Hopefully this one's quite straightforward. So it's responsibility of this board to sign off both the BCF overall plan and the quarterly report submitted to the National BCF team. The report sets out work reviewing 3 metrics: the rate of emergency admissions to hospital for people aged 65 plus, the average length of hospital discharge delay for all acute patients, and the rate of admissions to long-term residential care and nursing homes for older people. And as you'll see in the report, our performance on all of those 3 metrics is positive. But I'll hand over to Ed for
Thank you.
Any more detail. Thank you.
Thank you very much, Chair. So we'll do a double act on this paper. So thank you for the introduction, Ian. So this paper is around seeking a review and sign off of the Q1 and Q2 report. And also we'll just give some updates around what we know about 26-27 and actually 27-28 Better Care Fund and what that might mean for our local planning. So just as a reminder for colleagues, this is a national programme with an aim to integrate health and social care services. We have two sort of overarching objectives, which is around supporting the shift from sickness to prevention and supporting people to live independently in the shift from hospital to home. There are three parts, three funds: the Disabled Facility Grant, Minimum NHS Contribution, and the Local Area Better Care Grant. So in terms of 25-26 and the metrics, there really has been an increased sort of focus around the metrics and metric setting for 25-26. And there's a new National Better Care Fund dashboard as well to help us with benchmarking. As part of the Q1 reporting process, Norfolk was asked by NHS England to review our targets against the three metrics, because when we did it previously, we didn't have actual performance data. We were also particularly asked to look at metric 2, which is the discharge delay metric. So we did that. And following the review, actually no change. We made no change for metric 1. For the emergency admissions to hospital for people aged 65 plus. We did change the metric 2 discharge delays, and we worked very closely with the three acute hospitals in Norfolk and Waveney to complete a detailed review of this and actually set a more ambitious target there. And it was good to have that discussion in the context of sort of wider urgent emergency care work as well. The third metric around residential admissions, we did change as well, and the target was to sort of represent a positive improvement against our peer group. So I'm going to hand over to Ed, who's just going to give that more detail around the performance against targets now. Thank you, Ed.
Thank you. So as Karen has said, there's much more of a focus nationally and regionally on performance, and there's a national dashboard that's been developed. I would say, as a caveat, there are some data quality concerns that we have locally around the data, which we've been feeding back to the national team. But nonetheless, across all three of our metrics, as a local area, we're performing well to our plan, and also well as compared to the national average. Members of the board will note that we have always done fairly well around two of our metrics. The one that we have struggled with historically has been around residential admissions into permanent admissions into residential nursing care. So really positive to see improvements made there. And as Karen's hinted, there's a large transformation program within adults supported by system partners that's helping to achieve that improvement. In response to sort of requests from members previously, one of the things we're now doing as part of Better Care Fund reporting is asking the schemes that we fund to provide case studies so that we can bring them into this arena. And we've included a case study around NFS, our reablement service, which is jointly funded by the ICB and NCC as an example of the difference made in the paper. In terms of planning for 26-27, so at the time that we wrote this paper, we didn't have any details. These have since been published, at least an outline, so we can give members now a sense of where things are likely to go in the future. So it's been confirmed, the funding values for the NHS minimum contribution part of the Better Care Fund have been confirmed for next year and the year after. So we will have a 2-year sort of oversight of that funding, and there has been an uplift applied to that funding, which is good news for us locally. NHS England have confirmed they will be taking a stronger expectation that schemes that are funded through the Better Care Fund are sort of key integrated services that really sort of merit being in this funding stream, including those that focus on sort of areas of integrated delivery such as hospital discharge, intermediate care, etc. And there's a clear expectation that the Better Care Fund will be used explicitly to support the expectations and policy shifts set out in the NHS 10-year plan, including a link to the neighbourhood health planning guidance. The good news for us is that we've largely anticipated those changes locally, and all the work we did together last year has left us with a Better Care Fund in Norfolk that generally resembles that direction of travel. The focus of our joint work last year, as a reminder, was to ensure that the schemes that we currently fund in our Better Care Fund are those that benefit from integrated oversight and delivery. Our work jointly this year is around looking at services that are of key local importance that aren't funded through the Better Care Fund, and that's with a view of being able to bring that totality of that funding into a single funding stream, so that would enable our senior officers and members of this board to have oversight of the totality of our system investment in some areas, some key areas of integrated delivery. We don't yet know what the timeframes are, but we're fully expecting, we'll probably be expected to have a final plan for next year by the end of March. So our proposal would be to take the sort of outline of that plan to the next meeting, which I'm assuming will be in early March, so we'll be able to have a discussion around what that plan is looking like. The only other thing I wanted to add, just as a sort of shout out to our team, we were asked, Norfolk was asked to present as a kind of best practice example at a NHS England ADAS event on the Better Care Fund in November. So I went with members of the team and we presented on the good work we'd done locally, and there was a real kind of recognition and interest about the approach we had taken to demystify this funding pot and to start to get a bit clearer on outcomes that we're achieving for this investment. So that's all I would say, and happy to take questions, Chair.
Thanks, Ed. Yeah, and I just wanted to say, obviously, you touched upon it, but the Norfolk First support, the case study here is really, really interesting. I think it brings to life what the money does, how it makes a difference, really. And as you said, it's been identified as best practice nationally, which is excellent, really. So we go from there. Brilliant. Thank you. Over to the floor. Alison.
Thank you. We've pretty much said what I was going to say, actually, Fran. I mean, demystifying the Better Care Fund, because I've sat in this room for a few years now, and at first it was just opaque. I couldn't make any sense of it. I didn't really understand what outcomes it was delivering. We were allocating money. Probably the Disabled Facilities Grant was the bit that was easy to understand, because it was allocated to the districts. The districts then, on a needs basis, allocated it to individuals to modify their homes to enable them to remain at home. That was easy. The other bit was totally opaque, and I really welcome this new approach. And as Fran has said, you know, the case study about the impact of Norfolk First support on one individual, and lovely to hear from a family member who's really saw the tangible difference that made to his father, is really, really welcome. So I'd just like to say thank you to the team for, you know, putting it in a presentation format that we can all understand, and therefore we can share with our communities, because I think that's what's most important, because otherwise you talk about the metrics. The public aren't interested in the metrics, they're interested in the outcomes for them and for their families. So this is really welcome, and thanks to everybody.
Thank you. So Ed, Claire, then Tracy. Ed.
Thank you, Chair. On page 233, the last point there. Is it not on?
No, it's Ed first. And then
Oh,
yourself,
sorry,
Claire.
I thought you said Claire.
You're after Ed. It's okay. Ed.
Yeah, I was going to mention metrics. Maybe I'll backtrack now, but I do pore over the metrics regularly, and I see the national benchmarks on a weekly basis. And on the discharge metrics, Norfolk and Waveney is regularly either number 1 or in the top 5 nationally, which is a great reflection on the kind of the collaboration. And a good example of that is the trusted assessor model in West Norfolk, which, you know, Ian and others are involved with, which is really exemplary. So we should be really proud of that, because that is around outcomes, isn't it?
Lovely. Thank you. Claire, it's definitely you now.
It's definitely me now. Okay. Yeah, I was so eager.
You
As noted, as I said on page 233, Norfolk's currently on track to achieve our targets against all 3 metrics. It would be good to know even more detail about the key drivers / enablers that have led to this improved and above average statistic for Norwich, being from Norwich City Council as I am. Examples are given in this report, but as it is such an achievement, this would be really worth knowing.
I dare say we could find those. Yeah.
Yeah, I can definitely come back to you with more detail on the Norwich focus. In terms of the general kind of why we've seen improvement, that is in the very small print in the attachments, but I will read it out just to remind us about, for example, our local ambulance service having the lowest conveyance rate. I'm really proud of the work that colleagues have done around the urgent coordination care that is seen as an exemplar, and they are converting sort of around 100 999 calls to alternative provision now, so that I think that is a real positive, and sort of building on our urgent community response and the virtual ward occupancy rate. So I think that's really positive, and I think with the sort of planning guidance, and I think there's much more to do there, and there's a real focus. But I will come back to you on the Norwich specifics. Thank you, Councillor.
Thank you. Tracy.
Yeah, thank you. Really good to see those improvement in performance targets, and actually just sort of demystifying the Better Care Fund and some of those metrics and the funding streams, because it is, I know, a very complicated mechanism that you're working to. I just had a question in respect of some of the change in the targets themselves. So I was looking at the residential admissions and long-term support needs, knowing that we want people to return home, re-abled, that's the best place for them to be as quickly as possible, not going into residential care. So with the change in the metrics from the original to revised, are we seeing less admissions overall to those residential accommodations? Is that something that is absolutely on that improved trend?
Thank you.
So yes is the answer to that question. We are seeing a reduction in terms of the permanent residential placements, and interestingly there used to be a metric in the Better Care Fund that was around reablement and whether folks were still at home 91 days later, which enables you to then very tightly sort of draw that line. That is going to be back in the Better Care Fund from next year, so we'll be able to see that. But I suppose that speaks to the queries earlier. You know, the NFS or our intermediate care offer is a key driver, but there are other things we fund through the Better Care Fund that perhaps don't get as much attention that are achieving that. So yes, we are on a downwards trajectory, which is really positive.
Thank you, Ed. Thank you. There's no more questions. I think that's been a really good debate. I mean, as you say, this is a technical document to an extent. However, it affects real people's lives every single day. So, and for me, I think the case study really brings it to life, as I say. So it's about real people and real outcomes. Christine, do you want to come in?
Yeah, I just wanted to pick up with Ed. The last 3 times I've been to the meeting, I've asked about other people being involved in the BSF as well, particularly in terms of reductions of discharge, and whether or not that's been considered. Particularly, I note that I can't see any independent care involved in any of these schemes, and I just think it would be a worthwhile exploration of different perspectives. Thank you.
Yeah, I think that's a fair challenge. And I remember saying last time it's about us explaining how those stakeholders are involved in the transformation programme. You're quite right, Christine. I'm sure someone takes actions here, but let's make sure that we bring that back next time.
Lovely. Thank you. Thanks, Christine. Yeah, okay, so we've got nobody else? No? Great, thank you. Yeah, thank you. So the recommendations on page 231 is to agree and sign off the Better Care Fund Q1 and Q2 reports, which we have to do legally, and also to support a presentation of the Q3 report and an update as to the planning for 26-27 at the next meeting of the Health and Wellbeing Board. So I really welcome that. I know from conversation I had with Ed and Karen earlier on that there are lots of conversations going on with lots of different agencies to see how we can make our work better. Let's just put it that way, which we should always be doing. But there, so I welcome that. So are we happy to sign off that recommendation? Yes? Lovely. Thank you very much. Thank you, Karen. Thank you. Ed? Andy? Thanks. So next item, item 9, which is on page 252 of your papers, is the Norfolk Drug and Alcohol Partnership Annual Report, which is once again a document we need to bring through here, get signed off. So we've got a number of people here. So we've got Suzanne is going to introduce, and then we'll pass over to Paul, Rachel and Amanda. Is that right? Yeah, okay. Over to you, Suzanne.
Thank you. So I think this is the annual report from the Norfolk Drug and Alcohol Partnership, setting out the really significant work programme that they've been leading this year. And I believe Rachel, who's our NDAP Partnership Manager, is going to present the report, ably supported by Amanda and Paul. So I'll hand over to them. Thank you.
Thank you.
Thank you. So yeah, I'm here today to present NDAP's report for the Health and Wellbeing Board, to just acknowledge and report the recommendations that are in the report and to highlight the progress that we've made as we continue to align the work to the harm type strategy and our local priorities. So we work collaboratively with over 30 organisations in the partnership, and we also work in conjunction with the relevant partnerships such as the Safeguarding Adults and Safeguarding Children's Partnerships, Community Safety Partnership, and we have developed some local priorities. They're detailed in the report, but I will go through them. So we look at these priorities as a whole system approach. So our priorities for 2024 to 2026 are to embed the voice of lived experience across the system, improve outcomes for those with complex and unmet need, respond to the emerging drug trends, including ketamine and synthetic substances, tackle exploitation such as county lines and cuckooing, develop a dual diagnosis pathway, and ensure continuity of care from prison to community treatment, building workforce capability across the sectors. The groups are all chaired by subject matter leads, such as Sue Marshall for the Drug and Alcohol-Related Death Panel, Angela Freeman for the Ketamine Task and Finish Group, Rachel Chapman chairs our Children and Young People's Group, and Dee Lunn from CGL are Reducing Harms and Unmet Need. All activities in those groups are linked to the local and national priorities based on evidence, and they have action plans that are developed for each group, and those action plans are linked to our overarching delivery plan. So we've got some key achievements from over the last year. So NDAP has delivered significant progress against our priorities, which are detailed, and I just wanted to highlight a few of those. So our progress against our national outcomes framework, which is a monitoring framework set out in the Harm to Hope strategy, and we also have our local priorities, and those are developed and monitored by myself and then reviewed at our quarterly strategic meetings via a dashboard. In response to synthetic substances, we have increased the availability of naloxone to both service users and frontline professionals and developed a synthetic response plan. That response plan links into the work that we're also doing and supporting with in relation to planning for festivals. And our synthetic response plan also provides guidance and resilience over holiday periods to reduce the risk. We also have a comprehensive free training offer for frontline professionals. So for adults, for those in frontline adult roles, it's about understanding co-occurring conditions, trauma-informed approaches, heroin, methadone, nitazines and more. And at the time of the report was written, there was over 1,000 places offered for frontline adult workers. And in relation to children frontline workers, those are children workforce, we have bespoke sessions for them which have been developed in consultation with the workforce on topics such as understanding substance use in children and having conversations with children and young people about their substance use. NDAP was able to also secure some funding through the serious violence duty to pilot drug testing on arrest for violent non-trigger offences, and this will be utilised also within the Winter of Action plan. Ketamine is a priority area for NDAP, and this work has meant that Norfolk are now leading on some innovative work in other areas, that other areas are reaching out to discuss our plans, and we're also sharing the best practice with them. And in particular, the things that we're sharing is the EuroCet pathway that has been developed with the Norfolk and Norwich Hospital between CGL and Unity, our multi-agency approach to support and training in ketamine, addressing the gaps in pregnancy advice, and working closely with the local maternity and neonatal system to do that. We also have a local ketamine awareness raising campaign that is being developed, and we're working in partnership with the City College Media Learning Company, which is developing bespoke productions for over 18s, 15 to 18-year-olds, those who are neurodivergent, and parent and carers. Funding has previously been allocated annually, but OGHID have indicated that it will be issued as a 3-year award with allocations to be announced. With that, is everything. Is there any questions?
Thank you. Penny.
Thank you. I welcome the report. Obviously, I represent Children's Services here today, and there's one thing which I have also spoken to Fran about, is that ketamine is in vapes, and children are using that. Now, unless I've fallen asleep through national advertising on the television, because that's the only place where I would see these sort of adverts, I've never seen anything as yet regarding vaping and young people. Young people shouldn't have vapes, full stop. So they are obtaining them through asking older people perhaps to buy them, or whatever they're obtaining them. They shouldn't be in possession of them, full stop. But to use these other drugs in them as well, obviously it is all illegal, and I know our teams here for Trading Standards and everybody else is really doing an excellent job in trying to stop the sale or cease the sale of these. However, but on the national picture must be the same as it's here, and I have not seen any national promotion against it from any health organisation. This for me is one of the most, apart from, there's a lot of dangerous things for children and in and around children, but this vape business for me, having raised it a number of years ago in this meeting, where 9-year-olds are being sold vapes outside schools in the north of England, and I raised that here. But for me, it is a danger we don't know about. We don't know the full consequences. I read instances where young people have been addicted to vapes and their lungs have collapsed and they find themselves in hospital and all those sort of things like that. But I know locally we're doing our very best, and obviously you probably can't ask the national picture, but it is such a flipping issue that I don't feel that it's being addressed as I feel it should be addressed, being the Cabinet Member for Children's Services. So for me personally, the report is most welcome, and obviously Amanda and I know each other for many, many years, and she knows my views on these things, but I've never seen anything about this nationally. I think we need to push it locally as well, through all our channels, through all our partnerships, but it needs to be significantly raised, because the damage it is doing to the next generation coming up, and the impact that will have further along on the NHS. So it needs to be stopped at source. So as I say, I welcome the report. I think you're doing a fabulous job. I think the policing are doing a fabulous job as well, and everybody is. But we still don't come out and say, right, this is really horrendous for you. Why on earth do you think it's safe to use these? Thank you.
Thank you, Penny.
Yeah, I can come back on that. So agree, vapes is a massive issue. And also it's an issue that the young people's group have picked up on and are working with. They are also linking in with the Vaping and Nicotine Alliance at the council to look at that. There is some work going on around awareness raising around vapes. And I think there is some national campaigns in planning that are due to happen. But the timelines and stuff, we haven't been made that clear. But it is something that we are looking at, and we are also linking in with schools to try and reduce some of those harms. So, for example, the designated safeguarding leads of schools are contacted around any drug alerts that happen. So if there's any suspicious vapes or anything like that, they are alerted. We are also offering training to professionals around those things, and vaping is an area that we are looking at. We also work closely with some of the trading standards around identifying any risks so that we can share any of that. And again, it is an area of update that we want to do, but it's one that is a national problem as well. So we are looking for best practice that there is in that area, and have linked into other areas that are doing some more innovative work on vapes. There is also a system which we shared with all the partners in NDAP, where if there are suspicious vapes identified, then these can be sent off for testing as well. So there is processes that can be followed if there are incidents of concern.
Thank you. I've got Dan, Tracy, and then Liz. Dan.
Thanks. Two areas I wanted to ask about. One of them follows on from the last question, so I'll start with that one. I'm just a bit concerned about what's called an emerging trend. For example, ketamine we've been responding to in Norfolk for decades, and it's been around for even longer than that. And actually, you mentioned yourself about the NNN's great work on long-term chronic use. So I'm wondering how set up we are to respond to emerging problems. I mean, vaping could be in that category as well. That aren't actually emerging. They've been with us for a long time. And the other one is almost at the other end of the extremes, and that's around dual diagnosis pathways. We've had dual diagnosis strategies in Norfolk for decades as well, that have been here or not been here. And I'm wondering what, this is more of an offer, what we as a partnership and board can do to actually make sure that the changes in practice actually happen. We still know that there's providers who bat people between mental health and drug and alcohol services, which helps nobody. And I'm sure the strategy again will try to address that. But there's a block, a long-term block there. Is it commission? Is it contract performance? What is it that's actually stopping that practice changing? So two extremes really. How do we respond to things quickly? And how do we actually make sure those thorny long-term problems, what assistance do you need to actually make sure those services do what the strategy says it's supposed to do? Thank you.
Thanks, Dan.
I'll answer the emerging trends. Paul, did you want to do the dual diagnosis? Because that's your... so in relation to emerging trends, one of the groups that we have within NDAP is a data and emerging trends group. So it is around getting all of the professionals in the partnership together to kind of look at data we're getting. So we look at things from the prison, the community, national data that we have, to identify things. So ketamine has always been around, but it's been probably the last 2 to 3 years we've actually had a spike. So we monitor things like ambulance data, so looking at overdoses. And actually for the last 18 months, ambulances have been called out a lot more for ketamine overdoses than they previously had. So it's about looking at kind of the broader picture and kind of identifying not only if it's being used, but actually the harms that it's developing. And that's something that that group identified through the ketamine clinic by actually, it wasn't really it was supposed to be just for substance misusing patients at the hospital, but then they realised there was a thing. And it's when we spoke to them that we identified that they were working in isolation. So again, it's about identifying for partners and upskilling them. So it's something that is more of an issue in Norfolk than it has previously been. And actually the age ranges of those using the demographics have changed, and identifying pockets of that. So we have the group set up so we can actually start identifying them and then looking at kind of developing a partnership response as quickly as possible to that, for things like synthetics, and again, quickly identifying any risks or harms, and then we can quickly develop that response to them. And Paul, did you want to talk about?
Yeah, in relation to co-occurring conditions, we've been doing a lot of work with the ICB around this, and having worked in the system for over 20 years, I'd honestly say that we're seeing more progress now than what we've ever seen. We've got a clinical psychologist that we fund that sat on NSFT's transformation board, who has been reviewing policies and procedures internally. Also, we set up, after doing a workforce survey of the mental health and drug and alcohol workforce around training and integration. We've got a clinical psychologist also now based, an NSFT one based within treatment services as well, within drug and alcohol treatment services. And at the moment, the lead within the transformation board is looking at all of their policies. But it's a big shift in culture, and it takes time. And I always see it a little bit like an iceberg. There's lots of stuff that's going on behind the scenes, but by the time it gets to, I suppose, frontline delivery, it's going to take a little while for this to be meaningful. We could produce a pathway, and within a few years, people may not necessarily use that pathway to bring about real systemic change. We're having to really engage with the workforce in relation to that. And I think, your offer of how organisations and partners can get involved in that is well received. And I would say that being involved in the NDAP partnership board is a really good starting point for that. And yeah, it really is. It's a big long-term piece of work that covers everything from anxiety right the way through to psychosis. We were fortunate to have input into the wellbeing specification in relation to drug and alcohol, and there was some quite significant changes made in relation to that. I'm aware that CGL are currently in discussions with the Wellbeing Service around them delivering sessions out of CGL's premises as well at the moment, and I think that's something that we could look at expanding once that's in place. But there is a lot of work going on, but there's still loads that need to be done.
Thank you. Amanda, do you want to comment?
As Rachel and Paul were saying, the partnership are really committed to co-developing, co-funding, listen to service user voice as well for all of the work that they do, so that this partnership board doesn't work in isolation. It works across our children's partnership, our adults partnership, our community safety partnership, and we're actually finding that we're a stronger partnership network together, making those solutions. So again, no one's duplicating, there's no dual commissioning. We're making sure that with the resources we have, we use them in the best space, which is evidence-led as well.
Lovely. Thank you. Tracy.
Yeah, just adding to what Amanda said, which I was going to say, but Amanda said it very well, that the NDAP is a true partnership group. So I have the privilege of chairing the programme group, which directly brings those priority programme areas together. And the kind of the collaborative working in those groups and the difference they're making, you can actively see, and certainly the service users' feedback from that is really highly focused and is really positive about the services that are commissioned and about the approaches to how partners work together, particularly the response to those synthetic substances. I mean, we've saved lives, I think, in Norfolk as a result of that response and action plan, which I think is really positive. And I've just had pop up my screen a meeting I wish I'd been at today, but there's a meeting around sort of reducing harms in vulnerable women, which is really topical and key at the moment. And so I think NDAP does respond to those trends, does respond to the needs, and I think it is a really proactive approach to how you're all working together.
Lovely. Thank you, Tracy. Thank you for that. So I've got Liz, Joe and Tim. Liz.
Thank you. Thank you very much for the report. My question really is, I'm wondering whether the community alcohol partnerships are part of NDAP or not. So that's the first part of my question. And depending what your answer is where I go next.
Thanks, Liz.
So, yeah, the community...
You need to turn. Sorry, it's off now.
Yeah, the community alcohol partnerships are part of NDAP, so we are linked. So I do get invited to some of those meetings, which I attend where I can. But again, they often come to the data and emerging trends groups because, again, they're seeing a different cohort and their work.
Be running as actively as they have been in the past, certainly two, and they're not being mothballed, but they're sort of downgrading themselves. And that's because of a lack of capacity within the police and also the local high schools as well. So it's worrying for me because I think they're doing, someone's mentioned the good work of trading standards.
One is related to a new focus on women's access to treatment, but there was no sort of detail about it. And then a new reducing harm group focused on women and alcohol related harms. And then following on from that, domestic abuse related death review. What does that count? For example, does it take into account women who use alcohol to self-medicate against domestic abuse? And if they're being denied access to treatment by an abusive partner, I think there's a lot to go into there. I'd be interested to know exactly how much. You're looking at. And then the second bit, I was just astonished to read, CGL have produced packs for people being released from prison without a tent. And if we're releasing, they're vulnerable people being released from prison with no accommodation. Do we have stats on how many there are in Norfolk from the three prisons named in this report, please?
Can I just make a comment on that, Joe? That when I was portfolio holder at Broadland, the first protocol I ever signed off was with Breckland and Norwich City Council was exactly around this, was ensuring that people did not become homeless when they were released from prison. And I know that 25% of people from Norwich currently are homeless, which is just absolutely outrageous. But I know we put a lot of stuff in place because there's a duty to refer. If you know 56 days before someone is released, you know, you absolutely know when someone's going to be released. So I think there's a lot that the not just the districts can be doing, but all of their partners to ensure this doesn't happen. And I'd say that at any time of year, but particularly this time of year. You know, I mean, you know, why wouldn't you, dare I say, re-offend and go back in prison if you're going to be on the streets in the cold and wet? You know, so no, I take your point. I think it's a really important point. Thank you. Over to you. Thank you.
To go back to your last point first around the homelessness and prison releases, I can't speak to the stats on those who released homeless. That's not something that I have available. But we do have a continuity of care group, which is around supporting those who are in prison to access treatment on their release, which that is a prison in reach worker who goes into the prison and works with them. So they would be looking to try and support with housing as much as possible, but also it's about linking in to getting them the treatment on their release. And unfortunately, obviously, housing is a significant issue, which again, CGL doesn't have. You know, they can have referral rights and stuff, but it is an ongoing issue that we are working with partners to try and identify those at risk and high harm. But yeah, it's something that is beyond kind of CGL's capacity at that time. But they are making sure that people are as safe as possible on their release, so making sure they've got an naloxone and making sure that they have appointments so that they have some contact with services and they can then have a support worker to try and bridge some of those gaps that there are for them. In relation to the women's accessing treatment, so there isn't much information on the report because the group actually is the first group is actually right now, and we've done a focus group around getting speaking to women about identifying what their barriers to accessing treatment were, and the group is going to be talking about identifying what those key themes are and what activities we can do to kind of support some of those plans for women. And so some of that will be around women who are using alcohol, but also those who are using substances as well. So the group is actually looking at kind of identifying what kind of the priorities we're going to target first and what is possible within the group that we have for that. And then in relation to the, I think you mentioned the DARD, that is a drug and alcohol related death panel. It's frustratingly has the same name as the domestic abuse related death. So actually it's a drug and alcohol related death panel. So we do have themes within those panels. So one of the panels was to look at women who've died from drug and alcohol use, but it isn't linked necessarily to domestic abuse.
Sorry, can I come back? Because there is a domestic abuse related death review, and that was what I was specifically referring to. What does it count? Does it take into account women who use alcohol to self-medicate because of domestic abuse?
Councillor Rust, I can come into that point. I oversee the domestic homicide reviews, which is your domestic abuse related death reviews. And we do look at all the indicators of substance use with victims of domestic abuse, sadly, where they have died. And we ensure that we have our service providers, our drug and alcohol service providers, on those panels as well. We listen to the families, we listen to were there any barriers for that individual to access those services? Was it the perpetrator? Was it that that victim wasn't in that right space at that right time to be able to access the service? How can we as partners ensure that every time they need that service or every time we can help them access that service, we are there and learning lessons as partnerships to do that? You can read all of our domestic homicide reviews on our external DHR website, and we do have reviews on there where drug and alcohol use by victims as part of how they are managing themselves, not the perpetrator, who should be accountable for their behaviour, but how a victim is using that to manage their situation. And the lessons that we have learned in our domestic homicide reviews, we have practitioner webinars, information, communication, learning lessons. We expect all of our stakeholders, our CEOs, to be ensuring those lessons learned are translated through their entire agency as well, so that when any practitioner goes into a home, they can recognise if there is a victim of domestic abuse who is using drugs and alcohol to cope with that level of abuse as well. Each DHR is very different and the terms of reference will be very different, but when we have a look at all the chronologies, including the information we get from families, because some service providers may not be aware that victims are using drugs and alcohol, then we will talk to families as well, and we will utilise that because they do know their loved ones better as well.
Thank you. Tim, then we'll move to recommendations and you can have a coffee.
Yeah, I suppose I just wanted to highlight some positive energy, I think, based on this report and the work of the partnership. I was in a committee meeting for the ICB where I read the dual diagnosis report, and I really highlighted that as a really good piece of good practice. I do some work in Great Yarmouth around homelessness and lived experience. They produced a report around the dual diagnosis service, and it was really encouraging to see that the report delivered by the ICB and the partnership almost matched in terms of recommendations what the independent lived experience collective that I work with highlighted in terms of their experiences. So for me, it fills me with real optimism that actually from that report feels that we're doing some really, really good work and really take into account the needs of those with lived experience. So I really want to highlight that as an absolute positive. And yeah, it fills me with real optimism about the work of the partnership and where it might go in the future. Linking with Dan's point, I think the key bit is that how we making sure those recommendations are being put forward and how are they being tangibly kind of manoeuvred, I suppose, so that we're seeing those on frontline, so that actually frontline services are being able to take, use those recommendations and push them forward in practice. But yeah, for me, I just want to highlight that from what I've seen in that dual diagnosis report was really, really positive and fills me with real optimism about the priorities, I suppose, for the partnership moving forward.
Thanks very much, Tim. It's always good to end on a positive. Now, for me, I in my notes, I'd written about the co-production and learning from lived experience, which I thought was really, really important, actually, so important. And obviously the partnership working. The stronger partnerships we can develop, the better we can deliver. And for me, that's the most important thing there. Just one thing I want to highlight was around the focus on ketamine. Obviously, we've spoken about ketamine here, but there is a regional conference at the football ground on the 24th of March next year. I don't know how many of you have been invited. I have, but as many of you as possible can attend. That would be really, really good, because I think it gives us a really rich understanding of where we are and what we can do. And as Councillor, Carpenter's highlighted, it's really important issue at the moment. We know it's an important issue. Obviously, it's highlighted here in the paper, and it's really good that we're having a regional conference to actually look at it. So there. Anyway, on that happy note, I shall release you to have a cup of coffee and end this message, this Health and Wellbeing Board even. Thank you. So thank you very much. If we can come back in at 11:30, we'll be almost on time. Thank you very much. See you at 15:15. so we shall officially start the Integrated Care Partnership for Norfolk and Waveney. Okay, so welcome back, everybody. So I'll just start the meeting right now. We've got apologies from, well, we had already noted them, so they're already noted. And I say Mark and Patrick have now left too. So the minutes of the meeting on the 3rd of December, we need to agree them. That's on page 4. Once again, I think there's a couple of typos, but nothing too substantial, I've noticed. Are we all happy with the minutes? Yep, excellent, thank you. I'll sign them. Do we have any declarations of interest on the items here? No, I see none. Excellent. I have no updates and there are no public questions, so we'll move swiftly on to the first substantive item, which is substantive item, it's item 6, which is preparing for seasonal pressures for 2025-26. And so it's over to Ed, and then it'll be Nick, Kirsty and Rebecca. So Ed.
Yeah, winter happens every year, doesn't it? So this is talking about what we're doing this year. Some fantastic work. I think one of the most evidence-based interventions is vaccination, and I'm pleased to say that Norfolk is right at the top of the National League table in many ways in vaccination, and the Norfolk and Norwich have done exceptionally well, as an example, with their flu vaccination. So loads of great work going on, loads of collaboration, and my colleagues will be delighted to introduce the paper. Thank you.
Thank you.
Great. Thank you. Morning, everyone. Nick Lynch, Director of Transformation, Partnerships and Place Commissioning in Adult Social Services. So, well, actually, Ed stole my line, which I was going to start with. Winter's not an unusual event. So we know, though, that obviously it brings challenges for some of our residents. Cold weather, seasonal illness. Obviously, we have the Christmas period as well during the winter season. And so as sectors and individual organisations, we also then face that pressure over the winter period. Many of those pressures or challenges we face collectively. So urgent emergency care is one good example of that, but obviously also we have our own unique challenges that we face depending on the residents we support or our individual roles and responsibilities. So really brief, I guess, on the national context, we'll mention vaccination as well in a moment. We've had various different national guidance this year for winter. We receive national guidance every year. Often it comes at varying different points. But certainly on the NHS and the social care side, which is the predominant focus of the paper today, we've had national guidance over the preceding months. I think it's fair to say that a lot of that national guidance is really heavily focused on urgent and emergency care. We know that that's a pressure nationally. It's also one that we see in our own system. And I think in preparing this paper today, we've also had a number of reflections from partners that for future winter preparedness, how we can increasingly focus on prevention is something that we probably want to talk about, particularly given the focus of the Integrated Care Partnership and all partners in the room. So today we're just going to quickly run through 2 key elements that are in the paper before we have a conversation. So I'm going to start by handing over to Rebecca, who's going to talk about the planning that's being coordinated by the ICB.
Thank you. My name is Rebecca Quinton. I work in the ICB as a programme manager within urgent and emergency care. I think it's important to recognise that we don't end summer in a less pressured state. So as we enter into the winter period, we are already a busy and pressured system. And we also have the context of large change programmes across all of our organisations and financial pressures too across the whole system. As Nick says, there has been national guidance issued, so we've had quite clear expectations around what we are to achieve as a system, and to help frame our planning framework over the summer, which started in June. The planning process included commitments to improve the vaccination rate over and above what we achieved pre-COVID, and also around how we work together as a system to organise our response to the pressures that we see. So locally, our planning round started in June when we met as a system with all of our providers to review how have previous winters gone and what lessons can we learn and embed into this winter. Our UEC alliances at place level were a really key part of organising and bringing together each individual organisation's winter plan and starting the discussion around how do we bring together, understand each other's risks and support each other as organisations as the pressures hit. So how does one organisation support the other with mitigating some of those risks? How do we work together to support our population? And how do we balance the risk across the system? In September, on the 4th, we had a winter exercise, which was a desktop scenario planning, where all of our system partners came together and went through 6 nationally structured questions. So we were supported by NHS England regional teams to work through 3 demand scenarios. So what would regular demand look like? What would pressure look like? And then what would extreme pressure look like? I think the feedback from all of our partners around there has been that that was a really collaborative event. It was really well received. And it led us to start to look at where do our plans not quite, where are they not quite as strong as we need them to be. So following that, there have been task and finish groups aimed predominantly around how do we flex and share our workforce, because that was some of the key risks from that event was around workforce, and maybe how some of our structures don't support the swift sharing of workforce between services. From the NHS side, in terms of operational and day-to-day monitoring, the System Coordination Centre will be responsible for looking at the live demand and pressures and enacting those plans and bringing partners together to facilitate the conversations and the actions from our risk cards. And I think just to finish from the NHS side of things, usually we would expect some additional funding and finance around this time of year to support winter pressures. We haven't seen this year nationally. However, where we have been able to find some local money, we have invested this into parts and infrastructure of our system that we know works well already. So earlier you heard in the BCF about the Unscheduled Care Coordination Hub, urgent community response and virtual ward. With a small amount of funding that we have been able to reallocate this year, we have invested extra capacity into those 3 services to support alternatives to hospital attendance and admission for our population this winter. I'll hand over to Kirsty now.
Thank you.
Thank you, Becky. Hello, good morning, everybody. My name is Kirsty Rowden. I'm the Director for Intermediate Care and Urgent Community Response, and I'm fortunate enough to work across 2 organisations I represent and work for County Council, Adult Social Care, as well as Norfolk Community Health and Care Community Trust. So I think just to follow on from Nick and Becky, I just want to emphasise 2 things really, a couple of things. One is our focus is always, and particularly around sort of the winter period, is about how do we get as many people as possible home safely and supported, because that is the best place for majority of our people, our residents, to be. How can we think about stopping people go into hospital, which is often called admission avoidance, and I quite like the term decision to treat at home. I think that has a much better flavour. And so we're doing a lot of work, as you've heard, around with the Unscheduled Care Hub and that real collaboration with all system partners. So we've been working over the last year around deepening that integration between health and social care, but much wider than that. We're doing a lot of work with acute colleagues, with our other community providers, with the Mental Health Trust, IC24, and the ambulance service. And it's really that shift that's having that positive difference, is how do we work together, how do we support each other? And there's been a real sort of shift in coming together and working as a wider system team. How do we help support and keep flow going over the winter period? Becky's mentioned already around the additional sort of GP cover, and we're really looking at how we can increase our occupancy and keep patients home through the virtual ward, a hospital at home offer. One of the things that we need to think about over that, particularly around this cold winter period, is around the really vulnerable groups. And I'm thinking about our homelessness across the county. So we've been working with Norfolk County Council's Housing and Capital Programme Service and their team, so that we've collated that key contact list of district council contacts, relevant services, so that each area, whether you work in an acute hospital, patients coming through an ED, or whether we see patients coming through community or flagging up through 111, that actually people our teams, our professionals are aware of what services are available, so we can really support the very vulnerable people over the winter period. So I think that pretty much that's kind of where we've got to. And I don't know whether you've got any questions. Thank you.
I think that's it. Thank you.
Thank you. Over to the floor. Any questions? Oh, Suzanne.
I was just going to comment really in terms of, first of all, the vaccination rates. It's fantastic to see. Really commend the hard work that people have been doing across many organisations, including health and care, in terms of the numbers we're seeing. And it's really good to know because, as Ed said, it's really one of the most effective ways to stop people from getting ill. But also, in terms of prevention, some of the most simplest things can be the most effective, and some things that we can all do to help prevent illness. And things like mentioned in your paper, the infection control work. So if we all washed our hands a bit more and stopped spreading the bugs, that would be a really great thing. But also keeping warm and well. I noticed you also mentioned that in the paper very briefly. Keeping warm, we know, is a really important thing to do when you're vulnerable. And it can stop a number of things from occurring and stop you from going into hospital. So these are things we can all do to support. It doesn't have to be the more advanced, sophisticated things. Prevention, as we know, is better than cure. So thank you very much for all your hard work.
Thank you, Suzanne. You say keep it simple sometimes. We overcomplicate life, generally, actually. Adele.
Well, I'm on, that's good. So on the vaccination rates, just I think it's important to recognise that it's a fabulous job that the NNN have done, but in terms of all of our organisations are not necessarily adding to the national stats, and EC have got a 71% staff vaccination rate at the moment, which is really good. But I just wanted to say a little bit more about the Unscheduled Care Coordination Hub. We heard about it earlier in the positive work and the BCF. But if we just sit and have a little reflection on the work of the Unscheduled Care Coordination Hub and how it has really brought together the Norfolk and Waveney system as a whole team to respond into keeping people healthy and well at home, I don't think we recognise well enough the hard work and the effort of the team that have coordinated that to make it reality. So I think it's good that it's come here today in two different forms, but we really should celebrate the unique change that it has made as a Norfolk and Waveney system and how our patients and our communities are benefiting from it.
Thank you. It's really good to highlight some good work. Did you want to say anything or no? I'll move on. No? Okay. Liz?
Thank you. I just wanted to refer to page 26, Appendix 3, 1.1, which is about the intermediate care. And I note in the report that you're anticipating times of pressure and spikes in demand for immediate care, which includes reablement. And I'm just wondering what our confidence levels are that we have got sufficient reablement facilities in place across the districts, because obviously that varies from district to district. And as an area with the highest number of older people in North Norfolk, have we actually identified what level of demand there could be in those spikes? And have we got the capacity there to resolve that?
Thank you.
Yeah, thank you. A really good question. So in terms of demand and capacity planning, yes, there has been county-wide demand and capacity planning that then, or system-wide, that then it's broken down into individual areas. In terms of the spike, so generally we see higher demand during the January to February period. Although I would say I think probably a number of partners in the room are feeling that spike a little bit earlier this year in terms of now in December. So then in terms of the availability of reablement, the way that we manage that demand broadly is that we now have a set of commissioned providers called Caring for Better Outcomes who can essentially up and down the amount of reablement that they're able to provide as required during the winter period. So our confidence is we've got, I would say, a strong plan in place that as those spikes, if they do happen, that there is a provider there who can meet that. Those Caring for Better Outcomes providers are based in the places across the county as well. So it's not just a Norfolk or Norfolk and Waveney wide offer. There is one per place. Obviously, I guess as we go through winter, I'm sure we will have to adapt that depending on when those spikes come, because obviously the modelling can only go so far. We don't really know, depending on, as we've discussed, flu levels, various other bits, when it will actually happen.
Thank you. Yeah, please.
Yeah, thank you very much for the question. One of the things that I'm keen to highlight is we're doing some, we started a new initiative. It's at early stages, pilot stages, around what we're calling Reablement Plus. And what we recognise is, particularly with older people, going home is frightening if you've been in hospital for a long time. And so actually, if we look at how we can put some more intensive support in, and often it's night needs that catch people out, our residents out, where they're worried about how they're managed overnight. So what we're trialling is how can we boost and make sure that we really give a really robust offer, so that people might be visited quite a number of times during the day, and they also know they're going to get some support overnight, so they don't feel alone. And what we're seeing is some really early and small results so far, but we're building it across all of our areas, is actually we're managing to keep people at home. But it's often that instant sort of early need when somebody comes out of hospital, when they think, how am I going to manage? So and that's really positive. So hopefully we can come back and give you some more feedback. Thank you.
Thank you. Kim?
Thank you, Chair. I just wanted to highlight a sentence I was really pleased to find on page 27 under the action points, which is recurrent investment in district direct services confirmed to stabilise service provision. I think we can all agree, those of us who have spent any time looking at the district direct services, is absolutely essential part of our system now. So having that recurrent investment is really important, and thank you for that.
I would suggest district director would be very helpful if it was 7 days a week rather than 5. But there's something else to think about. Maybe with the BCF next year. Thank you. Anna.
Thank you very much. Hi, Kirsty. I think one of the challenges we haven't really mentioned, everybody's aware of, but we haven't actually articulated today, is the increased acuity of the patients who are being discharged, and how we plan for that for the future. But we're seeing it coming in fast with a lot of comorbidities, particularly with dementia, and how then we manage. And I know we've been working quite hard on the step-down wards with NSFT, and having to move patients who are actually not safe in an acute ward or subacute ward, nor are the people that they are with. So how can one, or how do you look to the future about acuity mounting all the time, as we have seen?
Yeah, I suppose if I start on there, maybe Kirsty, if you want to come in. I think it's a really, really good point. I think it's a really good example, actually, of where our planning for how we meet people's needs really is a year-round one, because what you're describing, I think we see more heightened during the winter period, but is actually something that we probably experience all year. And I think part of our approach as we move increasingly to more of a neighbourhood level should absolutely pick up as well. I don't know, Kirsty, whether you want to, address how we pick up during our intermediate care services. Thank you.
Thank you, Anna. And I think you're spot on. We are all providers, all of us, whether it's patients coming into either an acute or a community hospital, we're seeing that real rise in acuity and the complexity. And I think that's particularly why we're doing so much work. And how can we look after patients and take them out of the acute setting as soon as possible, because we know that they deteriorate in a hospital setting. So, how can we make sure when we're building our team and our services, how do we make sure that we're wrapping around the support that's needed? One of the things we're doing at the moment around those really complex, what we call a pathway 3 patient, which is often patients who are very complex, who might have behavioural needs, is we're working closely with across our health and social care around taking patients out, pulling them out very quickly from the hospital setting, and then actually assessing their needs and actually what can we do. And usually those patients will end up in a long-term residential setting. well, actually we've had some really good results and we've got people home, but just by looking at patients' needs and thinking from another perspective, actually if we did this, if we put that in, and making sure that it's very personalised care, we can do something different around it. But certainly that high acuity is what is absolutely a picture that we're seeing across all of our areas at the moment. It's a real challenge.
Thank you. Can I ask a question? On page 29, I mean, you talk about additional agency social workers capacity for 6 months to support residents in the Norfolk and Norwich University Hospital. I mean, I'm not going to say anything bad about social workers because I think they do a fantastic job being a social worker myself. But I just wondered if we'd looked at if some of that work could be done by the voluntary sector. They may know the people in their communities better than a social worker, and would be a less expensive resource as well. So it's just something, if we haven't thought about it, maybe we should. Yeah, please do. Yeah.
Yeah, thank you for the question. That particular reference around the social worker is making sure we've got enough capacity and resource at the acute hospital. So in our acute hospital, we support patients to get home. We have an on-site team made up of either acute colleagues, our therapy team, our nursing team, and our social workers. And there's a real MDT around patients about, firstly, can we get the patient home, and then, you know, what support needs to be put in. And it's really important for our patients that need a formal care act assessment. We do that as early as possible. And so that particular reference around that extra resource is around making sure we're getting to people and carrying out that assessment. I do think you're absolutely right around what opportunities there are with the voluntary sector. And I think with our Home First Hub model, which basically is a group of integrated staff that are managing patients and transferring them from an acute setting into hopefully home or intermediate care. The Home First model includes the voluntary sector, district direct, health, social care, therapy. So it's very much, we're working at that MDT level to make sure, are we missing opportunities? Where could our voluntary sector partners come in and support a patient home? So point really well made.
From a cost perspective, obviously, if you've got an agency worker for 6 months, you can have a permanent worker for a year.
Yes.
So would that be a better long-term solution? Because as we say, we are talking about prevention. We're talking about this. I mean, we're talking about winter pressures here, but obviously, as we've said, this is an all-year-round situation. So I just wondered if it's something we should sort of think about. Lovely. Thank you. Thanks very much, everybody. So if we move to recommendations, they're on page 12. It's to receive the report, which we've done, and to offer guidance and comment on the winter planning and seasonal planning, etc., which I believe we've done too. So thank you very much. Are we all in agreement with recommendations? Yeah. Thank you very much. Thank you, Sir Nick, Kirsty and Rebecca. Thank you. Right. So item 7 is the Health Inequalities Update Report. So I'll just give you a minute to move. Lovely. Thank you. So over to Suzanne and then Tracy and Jamie. Thank you.
Thank you very much. So this report is the regular assurance report received by the ICP on the progress that's being made to implement the Health Inequality Strategic Framework for Action. And under that structure, we have 3 leadership groups. And I'm very pleased that Tracy and Jamie have joined me today, because Tracy's the chair of the Healthcare Inequalities Oversight Group, and Jamie's the co-chair of the Living and Working Conditions Group, and I'm currently the chair of the Health Improvement Transformation Group. So we're going to take it in turns just to talk to the relevant section. So handing over to Tracy.
Great to see you all again. So I just firstly, before I do that, I want to just give an update on some of the Year 2 priority actions that are underway. So you may recall that we come and we had year 1 priority actions and then year 2 priority actions. So I'm really pleased to say that we've appointed a joint post between the ICB and Public Health, a coordinator to kind of align the leadership groups together and also to take forward those first year priority actions. So some of those priority actions for that first year is developing our resource hub. So we are developing a digital resource hub for our advocates and for our organisations to utilise, which will have evidence base, data sets, webinars, learning opportunities, and we hope to be launching that early in the new year. We're also continuing to develop the advocacy programme. We built that on the core 20 plus ambassadors that were an NHS England initiative, but unfortunately they've paused that programme. But we're building on the 35 ambassadors that we had for this year and cohorts 1 and 2 as well, and further working to develop them to support how they embed addressing health inequalities. And they're really helping us to develop the resource hub as well, so we're utilising their co-production skills, which I think is really essential. So that's 2 really positive things in those year 2 actions. You may also recall that as part of the launch of the framework, we asked our organisations to make a self-assessment and to how we could support you to equip yourselves to actually make pledges to address health inequalities. We've had organisations take part in those self-assessments. We've had 7 from the voluntary sector, 3 NHS provider organisations, 2 from local authorities, and 3 across other sectors. So there have been some challenges with capacities to build and undertake those assessments, and then obviously build improvement plans. So we're going to do some further work in the new year in supporting other organisations to do that and agencies as well, which I think will be really positive. I think the coordinator is also spending a lot of time really working hard to develop the living and working conditions group, and Jamie's going to tell you a little bit more about the work going on in that group.
Thank you very much. Good afternoon, everybody. As Suzanne said, I have the privilege of chairing the Living and Working Conditions Group, and it's a group that has only started in gusto really this calendar year, but great representation and participation from a whole host of agencies, districts, various county services, the ICB and the voluntary sector as well. So you'll see in the report that we've broken our work programme down into 3 rough buckets of work, colloquially called a job, a friend, and a home. And we've tried to think about the things that we can do to augment stuff that's already going on in and across the system by way of our fora. So to give you a flavour of the work that we've been looking at throughout the year, in terms of that job area, we've been healthily involved in developing the model around the Connected to Work programme and acting as a critical friend to the rollout of that programme across the county. Under the home theme, we've taken some time to look at disabled facilities grants across the county, building on the work that's already in place from a network of colleagues across districts to think about the demand profile, the way in which we're deploying our resource, the barriers to making quick decisions and implementations, and any opportunities for integration with other similar services. We've also made strong links to the Homelessness Network, which is chaired by Leslie Burdett of Shelter, in terms of how we can better augment that work. And we've also looked at the relationship between quality of homes and health. So all work that's set up and in process, and expecting some further discussion around those topics. Under the friend or the community area, we've got we've had some early discussions around the way that we all collectively invest in community capacity and navigation, an area most organisations have skin in the game of, and some useful and constructive conversations in the new year about how we could better share, collaborate and utilise our collective resources to great effect, and building on that momentum that we all seem to have around community capacity and neighbourhood level working. In addition, we're taking a look at our next meeting around the deployment of Mindful Norfolk and how that could help support our residents. I'd say as a general observation, the work of the group is not to set up anything new. It's really there to try and build upon the great examples of things that are already going on, to join the dots, so to speak, but also to act as a platform and a funnel through which some of our local partnerships, and particularly health and wellbeing partnerships, can raise the profile of the work they're doing and think about scalability opportunities for things that really are demonstrably making a difference and could benefit other areas of our county. Thank you.
So back to me to talk about the Healthcare Inequalities Oversight Group and some of the work that we're taking underway within that group. So there's a lot of work really working with our NHS anchors as a whole, which is really important, and we're taking some work forward around improvement plans after our NHS anchors undertaken a board maturity health inequalities assessment themselves, which is really positive to have improvement plans within organisations. And we've had further guidance that there's a refresh framework for that, which our NHS anchors group has agreed to undertake. And also our NHS anchors are looking at how they can work together to support a health equity approach and a team approach across the ICS, particularly bearing in mind that the role of the ICB is changing as a strategic commissioner, and we'll need to look at all of our providers, our NHS anchors, to do some work together and embed and kind of work on addressing health inequalities, and also just building on the health inequalities framework, which we already have. I just wanted to point out one of our projects through the Community Voices programme, which is around women's health and listening to women's health voices. So we, you may or may not be aware about that we had some incentives to support the development of women's health hubs across Norfolk and Waveney, and our decision was to really let's ask women what they want, what insights can we learn. So we engaged and co-produced with the voluntary sector a means of engaging with communities and worked with 12 voluntary sector organisations, appointed a women's health champion to give some insights into what their barriers there might be, how we could improve services. And we focused on the 40 to 60-year-old age group. And unsurprisingly, things that came out were kind of access to screening was quite difficult and challenging. There were barriers, there was stigma. They didn't feel that they were always treated fairly or listened to when attending appointments. So we've taken all that learning on board, and we're building that into a training programme and how we set up the primary care network women's health hubs, which will be happening in the future. So we've really utilised that, kind of joining up with the voluntary sector to do that work around what matters to women in their health and how we can address those health inequalities, which is really positive. I've talked about the ambassador programme, which we're building, and you may have seen at the ICS conference that we had some posters about the work that our ambassadors have currently been doing as their improvement projects, so around the high intensity service users. There was other ones around improving dietetic health in underserved communities, and they're all available, I think, with the pack that came out after the ICS conference. And then just to say that we're taking a strategic commissioning review of our kind of plus groups and inclusion health services particularly, and what that outreach might mean for those communities. You've all heard of the WOW bus, and I know our colleagues in Suffolk have a B bus, a Wellbeing bus. So we're looking at what outreach, what support, how do we kind of get services out, support services, listening to our communities and what will work. And we've got a particular focus on our ethnic community groups, our inclusion health groups, and those areas of deprivation within our rural and coastal communities. So we'll be able to report back on that and what that means going forwards. And then I'm going to hand over to Suzanne just to tell you more about the work under the Health Improvement Transformation Group.
Thank you very much. So the main focus of the Health Improvement Transformation Group has been on smoking and on physical activity. And we know lifestyle factors are really key drivers in terms of health inequalities leading to those other conditions that are key drivers for health inequalities. So they've chosen 3 highlights to put in the report today from the programme. It doesn't cover their full programme, but they've chosen the Smoke-Free Homes project, the social housing project, where we're working with district councils and housing associations, providing training for staff and referral pathways to stop smoking services. They've held events, all aimed at supporting smoke-free homes. The second one in the report is the highlight on the Making Every Contact Count and Behaviour Change Training Workforce Development Programme, which has been really well taken up at the moment. 1,400 people across 100 different organisations across Norfolk have already received training. And it doesn't stop there, because there's an ongoing online community of practice masterclasses to really embed those skills going forward for those staff. This is something that the HITG really want to encourage organisations to embed within their own plans, because in order to be effective, it really needs to be delivered at scale across Norfolk. And the third one in the paper is the Active Now project, which is working with Active Norfolk, looking at the work that they're doing to support inactive populations, really targeting those that experience the greatest inequalities and working closely with health and wellbeing partnerships. Since it started, they've had over 11,000 referrals since 2023, and they're making a real demonstrable impact in terms of improving physical activity, which we know how vital that is for us all to keep going. So overall, in terms of health inequalities, I think it's really important to note the progress that we've made this year, the hard work that's being done, but going forward, we don't want to lose that momentum because we know we're entering a period of great change. We want to build on what we've done and really keep that momentum going forward. So thank you.
Thank you very much. No, it's very quiet. Oh, Dan.
Yeah, so I'm going to ask my usual question, if you don't mind, which is, obviously we're signed up to this, and we know under the financial resources priority that in order to address health inequalities, we need to target more resources in deprived communities, and we talk about that, and this wonderful phrase that's hard to say, proportionate universalism. I got it right that time, thank you. I just wonder if there's an opportunity at the moment, because we've backed this as a partnership, so we have agreed that we want to target more resources in deprived communities, but with the commissioning strategy in the ICB and with the 5-year plans that providers need to undertake, that was mentioned earlier, I just wonder what opportunities are to influence those plans to make sure that we can actually achieve that goal of targeting more resources in deprived communities. Thank you.
Thank you.
I think you're right, there are opportunities. I will look to Ed to support there, I think, to see how we could sort of contract for value and how we can have social value in our contracts and how we can have that approach to that we're working and targeting, I guess, as you're saying, Dan, some of our underserved communities that we know will have the poorest outcomes, but inevitably will cost our system more, I think, as well. So I think we are absolutely doing that, and I'm certainly having, you know, oversight with the work we're doing in those commissioning plans and intentions and strategies. So I will look to Ed to support with that, if that's okay, Ed.
Yeah, absolutely. I mean, I want to be judged by the impact in Great Yarmouth, North Lynn, South Norwich. That's the job, isn't it? So we're absolutely looking to do that. We've started with Great Yarmouth and Waveney as the sort of place we're looking to accelerate, and have just agreed £500,000 investment from the ICB for that place, and want to do really targeted work all across Norfolk and Waveney where the needs are greatest. So that's what we need to be judged on.
Excellent. Thank you. And I mean, obviously you talked about Active Now, but in the paper on page 43, it says about the return on investment. And it's so important, you know, you put £1 in, you get £22.45 back, you know, in savings. And that can be used elsewhere, that money. So, you know, if we can put more into prevention, the better, really, and address health inequalities, I think we're all for it, really. I mean, I don't think there's any argument in this room. I probably never ever will be. I hope there never ever is. But there you go. Okay, lovely. Thank you. I don't see any other hands shooting up. So if we move to recommendations, and thank you so much. Page 37, we're asked to, within our organisations, enable your workforces to support shaping the Health Inequalities Resource Hub, to support increased collaboration between Suffolk and Norfolk, and support the actions and development of 3 leadership groups, which include, but are not limited to, developing a systems approach to community connection, further development of the Smoke-Free Homes project and future business case for Active Now, and enhancing the system's health inequalities advocacy programme. Are we all in agreement? Yep, lovely. Thanks very much. Thanks, Suzanne, Tracy and Jamie. Thank you. Move to a final item, which is item 8, which is on page 44 of your papers. That's the 2024-25 Learning from Lives and Deaths, People with a Learning Disability and Autistic People annual report. So here we are. You go, let you settle down. Okay, so I'll invite Ed to introduce this, and then over to Andrew. Thank you.
Thank you. So it's a good build from the previous item, isn't it? I mean, this cohort of people on average live 20 years less than the average in Norfolk, in the Norfolk county. So it couldn't be a more important report. Andy will talk through all of the excellent work underway, but I guess one thing from me is we often look at going back to metrics, health checks, but that's not good enough because it's the action plan that goes with the health check and the quality of the action plan. So it's just making sure that we take a proper look at the follow through so that people are getting the right support at the right time.
Andrew.
Brilliant, thanks. Hi everybody, thanks for having me today. So just a reminder for people in the room, LEADER is a national programme and we review the lives and deaths of adults with a learning disability or autism with the goal of identifying issues with care and service access and trying to deliver change through service improvement. This is our 8th annual report. And we've also got an easy read version and also a video version which has been voiced by experts by experience, really to improve the accessibility of the report to the people actually who it's about and who it most concerns. So hopefully you've had some time to have a look at that. And this is the third time that we brought the report to this forum. LEADER as a programme, I'd like to note, sort of continues to be really well supported by a system that really does seem to want to make change to improve care and service access. And we see this through increased notifications and continued support with our learning interaction work, which I'll talk about in a bit. And as Ed said, this is really important because we continue to see a high number of premature and avoidable deaths, which requires continuous work to identify areas for change and take action to improve practice and tailor services to meet those needs. So what we do is we get a lot of information, we get a lot of learning from LEADER, so I'm going to go sort of through some of those key messages. So our age of death has increased, it's 63 years old. That kind of puts us in line with the national picture, but as Ed mentioned, is significantly under what we would expect for the general population by about 20 years. Our avoidable deaths are down, so 44% of deaths could be considered avoidable, which again is an improvement from where we were last year, but still far higher than what we'd want to see. To give the equivalence to the general population, you're looking at 22-23%. So there's a real difference there. And that's very much influenced by the high number of respiratory deaths, which we'll talk about. And those respiratory deaths come from sort of combined aspiration and other pneumonias. They account for 32% of all deaths of the reviews that we completed in 24-25. This is an overall reduction on last year, so we're seeing less deaths from pneumonia overall, but it's still a higher percentage considerably than any other leading cause of death. And as with the general population, there are still a number of comorbidities which we can really influence as a system through really good sort of public health and preventative measures. For example, hypertension is our second most common single comorbidity, and cardiovascular disease is our highest grouping of comorbidities in the reviews that we've done. So there's real areas for us to influence change and improve general population health. We see a mixed picture in things like our adherence to STOMP principles, so that's making sure that we are monitoring and really responding to psychotropic medication prescribing. Overall, we have seen a slight increase in our prescribed medication, and I think that's potentially because we're seeing an increase in our number of autism-only reviews, which I can talk about. But we have also seen a reduction in the prescribing for things like mental health conditions and challenging behaviour, which is what we'd want to see, as well as a decrease in the length of time that we're prescribing these medications, and that's also a positive. In other pieces today, we've talked about vaccinations, and our flu vaccinations continue to be really good. Our pneumococcal vaccinations has increased for the second year running. It could still be much, much better, certainly where I'd like to see it, but it's good to see year-on-year improvement. But we also need to pay attention to other vaccines as well, so non-respiratory. Our shingles vaccine uptake is relatively low, so that's an area that we'd really like to see improve. And we're also, taking into account the RSV vaccine rollout in the last year or so. So we're going to be measuring that moving forward. We mentioned annual health checks, and obviously that's a big factor. You know, for the first time we've achieved or overachieved national targets, which is really positive. But as so Ed mentioned, it's not just numbers, it's about the quality of that annual health check and you know, the quality of that health action plan. But it's also about equity across our area. We've got a 15% difference in our best and worst performing areas within Norfolk and Waveney, and that's a gap that we want to close. You know, we don't want where you live being dependent on whether you receive that annual health check or not. We're seeing a better approach to emergency admission, so improved respect forms, which is really positive. People are accessing, you know, emergency healthcare in you know, a way that they're prepared for, and services are prepared to support them. And we've also seen better support around end-of-life care, so less people dying in hospital, so dying in a place of their choice, which is again, you know, sort of something that we, you know, we want to continue. We've seen compliance with the Mental Capacity Act has improved, and we're certainly seeing a reduced variability. Most of the reviews that we see, people have multiple sort of capacity assessments, and what we want to see is a consistent approach to really good practice in that, and that's starting to come through more and more, which is really positive. So the best informed decisions really being made in the right way. So all of our learning, you know, it's really great to get that information, but unless we do something with it, it's not really beneficial. And I hope sort of the reports go some way to example all of the work that we're trying to do to sort of take that learning and, you know, push it out into real change within the community. A couple of main projects that I guess I really want to highlight. You may have seen about the emollient and fire risk work that we were doing. That's been a really, really great project that's had fantastic buy-in, and it's won the Norfolk Fire and Rescue Annual Award and the National Fire Chiefs Council Celebrating Prevention Award, both for partnership working, and it's also been further shortlisting for an Excellence in Fire and Emergency Award for collaborative working. And I think why that's important, I mentioned at the top about how much buy-in we get from the system in LEADER. You know, that wasn't a project that came with additional funding, it didn't come with additional resources. It was essentially buy-in from colleagues in community learning disability teams, social care, Norfolk Fire and Rescue Service, to, you know, pull the time that they had out of their day-to-day job to really deliver a project that's been nationally recognised. So just to sort of example, you know, how well supported we are by the system. I've talked about annual health check, and that really wouldn't be possible without the work of our health improvement team, which again have their own report and highlighting the work that they've done. You know, them along with primary care colleagues have taken our compliance from 51% up to sort of nearly 78 in the last 4 years. So their dedication to improvement has been really amazing. And, you know, our work around education and training. So as well as like the emollient training, we've worked on improving awareness of soft signs of deterioration, looking at Restore 2 Mini, really targeting skill gaps in our care colleagues, understanding that they're looking after far more complex people in a community setting, and actually what is our role to make sure that they're best supplied to do that really well. And also looking at, you know, our colleagues that are coming through the system. So we've really embedded LEADER, learning disability awareness, autism awareness within our undergraduate studies. And, you know, we've sort of pushed ourselves onto the curriculum for all undergraduate health and social care, except the medical school, but undergraduate health and social care colleagues, which has been, you know, really positive to get that learning and that change in practice in at the foundation, rather than, you know, 2, 3, 4, 10 years into a person's career. So that's just a bit. I'm hoping that's enough, but yeah.
Thanks very much, Andrew. Just one thing, can you just clarify, just for people to understand? Obviously, we talk about vaccinations and how important they are. And most people understand flu, COVID, pneumonia, shingles, but RSV, I would say most people don't have a clue what that even means. Could you just, you know, elaborate upon that, just so people actually understand what it is and the impact that it can have, and obviously the impact of vaccination can be?
Yeah, no, definitely. So RSV, now this is going to be embarrassing, I'm going to pronounce it wrong. Rhinus syncytial virus. I've pronounced that wrong.
Yeah.
Tracy will update
Respiratory
after.
syncytial
But it's essentially,
virus,
yes,
yeah.
definitely. And sort of there's a new there's a new eligibility, age-related eligibility, which, you know, as people with learning disability and autistic people live longer, which is what we want them to do, they're going to fall into that eligibility criteria. So as well as COVID, which you may have seen the eligibility has changed recently, it's moved away from just a learning disability diagnosis. We're going to be measuring that overall as part of respiratory health because it's linked to other sort of respiratory conditions, which unfortunately can lead to ill health and hospital admissions.
Yeah. Okay, lovely. Thank you. Thank you. Right, Alison and then Ian.
Thank you. Thank you for that really comprehensive report and overview. I think I was really interested and pleased to hear about the increase of uptake in annual health checks, but particularly picking up on the hypertension challenge. Is there an opportunity within because often autistic people may not engage with a health check, and I'm pleased to hear that, you know, they are in increasing numbers, but for those that don't, whenever there's an interaction perhaps with primary care, is there an opportunity for their blood pressure to be checked? Because it is one of those hidden things that people may have hypertension and not even know it. And it's often not until something else comes to the fore that you pick it up. So I wondered what opportunity there was, you know, if you've got somebody with these kind of conditions coming for something else, is there an opportunity to get health professionals to check their blood pressure? Because it seems to me that if we can't get them to a health check, we might still be able to pick up those with an underlying hypertension.
Thank you.
Yeah, definitely. I mean, just to clarify, in regards to the annual health check, it's just for those with a learning disability. So we don't actually have an autism-only annual health check program currently. But 100%, I agree. I'm a firm proponent of every contact counts. We do, so I was talking about the health improvement team, and I heard Tracy mention earlier the WOW bus, which is just an incredible sort of vehicle for getting out into the community, especially those with a learning disability and doing desensitization work, you know, just the opportunity to take a blood pressure and then actually seeing, you know, is there something off there, and then, you know, referring and directing to the GP. I mean, that's kind of one element of what we're doing. But definitely, I mean, we do lots of engagement work in events. We go to the Family Voice Conference. The health improvement team have made a big work of going to some of our specialist school provision, again, focusing on the annual health check from 14 to 17, which is something we really want to develop. You know, doing those blood pressures, sat monitoring, getting people sort of more familiar with, you know, those everyday health checks, which are so important. But I mean, yeah, any opportunity to, you know, getting people to take their blood pressure at home, being more aware of your blood pressure and actually what it means if, you know, we're seeing chronic hypertension over a long period of time. So I think it's education and self-care as much as it is contact as well. Anything that we can do.
All right, thank you. Ian.
Thank you, Chair. Like Alison, I really welcome this report. Obviously, people with learning disability are one of our 4 key care groups, and that statistic on difference in life expectancy is really, really stark, isn't it? So this board ought to be intensely interested in what we're doing around there. I really welcome the increase in coverage of annual health checks, notwithstanding Ed's point that we need to ensure that it's paired with effective health planning and follow through. To that end, the bit that really jumped out at me in the report was the screening coverage. So particularly low rates of uptake of AAA, cervical and breast. And I just wonder, can you give the board some assurance in terms of what we're doing to address that?
Thank you.
Yeah, so a large part of our work up to date has been through sort of the health improvement team, who do a lot of work within primary care, so raising the awareness of screening, some of the difficulties in screening for people with a learning disability and autistic people, and how to try and overcome some of those barriers, as well as doing work within care providers, care homes, nursing homes, on supporting people to respond to those screening programs. There are some issues which exist with outside of our immediate control. So, for example, how people are invited to screening. It's nationally directed, and whether that initial contact goes out considering a person's reasonable adjustment. So, can they read a letter that comes through the door? Is that going to be ignored, for example? Over and above the work that we're doing with national teams, we can't control that locally. But what we're doing is try to work with people directly, use these opportunities, health promotion events that we're attending to raise awareness, as well as, sort of through training and support for colleagues. I think one of the issues, we mentioned about AAA, but cervical screening and breast screening goes into maybe a wider issue that sort of Tracy might have referred to in regards to women's health. And I think an often area that we see missed is menopausal care as well for women with a learning disability and autistic women. So I think, some of it may lead into larger inequalities we see within health provision for women that, unfortunately, as with most areas, there's already an existing inequality, and then people with a learning disability, unfortunately, just have a harsher impact from that. So there is work there that we're trying to do, yeah.
Thank you. I've got a number of speakers. So I've got Alex, Kim, Mark, Christine, then Joe. So Alex.
Thank you. Mine's a mere observation, having been involved with LEADER for a number of years now. I'd just like to commend the team, because when I first started in this job, I think it was only about 20, we were in the bottom quartile in the country for health checks. And, there has been such tremendous improvement that it really should be highly commended.
Thank you, Alex. Kim.
Thank you, Chair. I just wanted to build a little bit on the health action plans and the sort of after people have had the health checks, then how do we support those people? And there's sort of a short list on page 77 of our papers, the first item of which is health promotion activity, which I'm quite intrigued to know what that means in the specific sense. I understand sight tests, dental checks, that sort of thing, but what does health promotion activity actually mean? And we mentioned sort of weight monitoring, but we don't mention nutrition specifically, so I'd be interested in sort of screenings on, for example, vitamin D deficiency, which can play into pneumonia susceptibility and things like that. So nutrition and health promotion activity, if that's okay. Thank you.
Thank you, Kim. Andrew. Are you right? No, you're on
there
there.
We go. So nutrition definitely, as well as we definitely sort of measure wider BMI with all of the caveats that you have to take with BMI for people with a learning disability and atypical sort of like body shape and how that impacts. We do a lot of work in regards to sort of nutrition and supporting people to sort of eat as well as they can. The primary difficulty that we see coming up with reviews in regards to sort of nutrition and healthy eating is actually how it conflicts with the Capacity Act and sort of providers in sort of people having choice and capacity to have choice versus, where their responsibility comes in to care for that person and make sure they have an access to a wide and varied diet. So a lot of our work is around sort of supporting providers in regards to sort of Capacity Act and making people have, sort of supporting people to have healthy choices. We did do a big piece of work a couple of years ago with our learning disability community dietitians. It was a project that was actually featured in the Learning from Action report last year that NHS England put out to try and improve the existing information that the learning disability dietitians had put out to support care homes in this programme. So it's about education, not just for the people with a learning disability, but for care staff as well. I often find that I mentioned before there's a really high complexity of needs within the people that our care sector colleagues are looking after, and we don't always reflect that in what we expect in regards to care and training, and I think nutrition's foundational to that. So that's some of the work that we've done. I'm not sure if that answers your question, but it's something that we're constantly aware of and constantly working towards, and also factoring in some other indicators like so, for example, our STOMP principles. We know that psychotropic medication can have a big impact on weight and how that plays as well. So we try and sort of look at all of the factors that influence that. I hope I answered the question.
Thank you. Mark?
Thank you, Chair. An observation, really. It's a really interesting report. Thank you very much, and I'll take it away and read it in some more detail. My observation is more around how this links to the previous item we've heard and the discussions around proportionate universalism. I'm looking at 7.8 area of deprivation and looking at the IND scores and the number of notifications there. So it's really just a, yes, absolutely, we must think about our most deprived areas, but this report highlights quite nicely, I think, that we mustn't forget the middle. You don't change that curve if we're not ensuring that universalism across the social gradient. Yeah, that's just the observation. Let's not forget those people that are hidden by the IMD data in the middle areas. Thank you.
Thanks, Mark. I mean, yeah, I would recommend reading the report. I always would, but particularly on page 95 onwards in your pack here, which is page 48 of the actual report, there's examples of lived experience. I think they're really, really telling. Actually, they're quite well. I found them quite heartbreaking, actually, in many ways. But you know, I think it's really important to read them to actually find out what actually happens to real people on a daily basis there or so. You know, so no, excellent, thank you, Christine.
Yeah, just thank you, Andrew, for the report. It's really enlightening, and an area that we've always known we don't have enough attention on. So in terms of information and support for people with learning disabilities, like you say, often it's where they are. They can't get the information. So it's sent nationally through a telephone often. They may not pick it up. They may not even use a telephone or whatever regularly. During COVID, we spent a lot of time in the vaccination planning programme around getting to people with learning disabilities because it had a low take-up. And a lot of what we found was because of the resistance and the concerns, and there were clinics set up around vaccination hesitancy and concerns around it. So I'm thinking about the fear of vaccinations and the fear of invasive assessments as well, smears, etc., which is hard enough to get your head around when you know everything, but when you can't, it's even more challenging. So I'm just wondering about supporting people that support people with learning disabilities and the education around that, and also the advocacy so people can help people with learning disabilities access that. Oh, I was thinking of shingles particularly. I've just had my shingles injections and I wouldn't wish that on my worst enemy. It was awful. So, and I know it's necessary, but for people with learning disabilities without that support, those figures aren't going to move terribly much. Finally, sorry, but is there something nationally that can be done about the way people receive vaccinations? Like, you know, with children, they have the nostril vaccination for flu. Is there some way we could not develop less invasive processes for people with learning disabilities? That's not for you, but I put it out there. I feel very strongly about it.
Yeah, we one of the big sort of things that we push and we work with the system to try and improve is things like reasonable adjustments. So, you know, is there a better way to support access to services? And I think that, you know, sort of is a perfect example of that, you know, where we can and how we can best provide reasonable adjustments for people to access the care that they, you know, that they want and need.
Thank you. Tracy?
Yeah, I'll be very quick because I'm mindful of time. So thank you, Andy. And just sort of responding to Mark, I guess, with the kind of the sobering, you know, 44% of the reviews show that the cause of death is avoidable. I mean, that is still quite shocking, isn't it? But I know there are communities with a learning disability and autism are one of the plus groups of the core 20 plus, so that those communities, those individuals will have that special consideration, and hopefully those sort of proportionate, universal, targeted approaches, I think, is key. So I guess my question to Andy is, you know, the most common single cause of comorbidity is epilepsy and the cardiovascular elements of hypertension. I know that's not necessarily knowing people and case finding people, but treatment not being optimised. So what can we do to kind of, from a clinical perspective, I guess, optimise the treatment and kind of have that focus? Is there more we can do, you know, in that area, really?
Well, I mean, the epilepsy representation isn't too much of a surprise. 30% is about what you'd expect from national figures as a comorbidity for epilepsy and a learning disability. And actually locally, because we have our community learning disability teams within Norfolk especially, generally we see our epilepsy very well managed and actually very well supported in regards to sort of reviews and response to any changes in seizure patterns. So in that sense it's really good, but I mean definitely there is room, I think, for I think it's understanding the need for follow through at times, and understanding that actually, whereas you know, somebody you know, treatment intervention is done, post intervention sort of support and advice, we're sorted. Some people need a bit more than that and a bit more follow through, and I think sometimes maybe that's not appreciated, what we don't see, and then we may see some backsliding or someone's health get worse. So it's being able to recognise the support that someone may need following, you know, whatever it may be, an intervention, an operation, a piece of desensitisation work, and understanding that we might need follow through and feedback rather than assuming that, you know, all will be well and we've done our job. Would be my kind of understanding. I'm not sure if that answers your question, though.
Thank you. Jo, and then we go to recommendations.
Thank you. I'm really disappointed to note that in West Norfolk, we only have 71% of people taking up the health action plan. And I wonder whether there's been anything done to identify the reasons why, and if there are any plans to try to tackle the fact it's the lowest in Norfolk.
Yeah, so so that 71% would be 71% of people that had an annual health check have had a health action plan, and definitely. So the PCN within the West have used some specific funding to have a specific role around supporting annual health checks, you know, in conjunction with the community learning disability team. That's been there for a while, but it's, you know, the idea behind that role is specifically around working with primary care colleagues and also working with members of the community to try and find out what those barriers are, reduce those barriers, and support people into annual health checks. So that is a specific piece of work that's been done over and above what our health improvement team have been doing as part of their usual offer across our footprint.
Lovely. Thanks, Andrew. And thanks, everybody. Yeah, I think it's been a really rich debate, as always, really, and this is such an important area. I mean, you know, the stark numbers, as you say, when someone's dying 20 years younger than perhaps they should, then we all need to sit up and listen, really. But I'll move to the recommendations. The recommendations on page 45, and we're asked to agree and approve the recommendations from the LEADER annual report and system learning, and champion advocacy and inclusion for people with a learning disability and autistic people in any discussion and or decision that may impact their health and well-being. I think we're all in support of that. So lovely. Thank you very much. So I'll formally close the meeting here, and thank you all for your endurance. I know I've overrun, so not a very good chairman today. So, but there we go. But I really would genuinely love to wish you all a Merry Christmas. You know, wherever you're going to be, whoever you're going to be with, have a lovely time. And I hope you manage to all have a break over Christmas. So the next formal meeting of the Health and Wellbeing Board and the ICP will be Wednesday the 4th of March. So I look forward to seeing you then. So take care, everyone. Thank you.